My name is Joe Big. I'm a PhD candidate here at London School of Hygiene and Tropical Medicine. I'd just like to start by thanking the organisers of this event, Astra London School, Icahn Institute of Molecular Biology in Indonesia, for inviting me to share some of my work with you today. It's kind of a nice follow-on from what Martin was talking about in his introduction to dengue. And I'm going to be talking mainly about the challenge of diagnosing dengue at the point of care and how future novel diagnostics can be used and combined to give improved case management for patients. So there are a variety of different ways in which dengue can be diagnosed. Namely, and the most common one is clinical diagnosis. So as Martin was mentioning, that the WHO has a series of criteria that can be used at the point of care in which people can be assigned as to being probable or suspected or confirmed dengue cases. In addition to this, we have traditional laboratory tests. So this includes looking at platelet levels, hematocrit levels, and this is mainly used to predict disease severity. Now, both of these methods are quite simple and they can be used by relatively simple equipment, or no equipment in one case. But one of the major issues with these is they're non-specific tests. Lots of other infections look like dengue, for example, COVID-19 or influenza, Japanese encephalitis. So people can quite easily misdiagnose based on just the clinical warning signs. And in addition, other infectious agents can have impacts on levels of hematocrit and platelet levels. So these, although are easy, they're not necessarily the best methods to use if you're looking for a specific dengue diagnosis. But in addition to this, we also have molecular and serological diagnosis. So this is predominantly used in a laboratory setting. So molecular diagnosis, including PCR or viral isolation, this is concerned with diagnosing or almost capturing the viremia that would be in a patient's blood. And like Martin said, after the viremic stage, you have the immunological stage, which is where you have antibodies that are elicited to the infection, and these can be diagnosed, or these serological markers can be captured using serological diagnostics such as ELISAs. And these are quite specific tests, and they've got more sensitivity, but the challenge with them really is the fact that they do require a lot of equipment, and it's quite difficult to get results at the point of care. But one of the first issues with these specific tests I want to talk about is actually just thinking about the course of the dengue infection itself. So if we, like Martin was saying, we have two types of infection. We have a primary infection and a post-primary infection. And more relevant to that as well is the fact that the disease progresses so quickly. So we have these 4 dengue serotypes, dengue 1 to 4. An infection with one of them can cause, your first infection with one of them causes a primary infection that results in the first period of viremia. And this viremic stage this first viremic stage can be detected because of PCR, because it can detect the RNA in the virus, or it can detect the NS1, or the non-structural protein 1 that's secreted from the virus, but is only present during the viremic stage of infection. Following this, you have the immunological stage, and you have the IgG response, and during a primary infection, this is quite delayed. This actually comes up to possibly around day 6 to day 9 of day of illness. And once this is elicited, we can see this will then render individuals protected against that serotype for life. But the issue is that IgG doesn't necessarily protect you against the other serotypes. So if you have a subsequent post-primary or secondary infection with a dengue, say 2, 3, or 4, this results in a post-primary infection. And this IgG, like Martin said, this doesn't protect you. This can actually exacerbate the symptoms because this IgG enhances viral replication in the blood and can cause basically cytokine storms that can result in more severe disease. So as a result, post-primary infections are major risk factors for progressing to severe outcomes. And it would be really important to know whether patients at the very early stage of disease are likely to be progressing as a primary infection or a post-primary infection. So we've been looking at this quite a lot recently, and we've been looking at as to whether or not we can combine serological and molecular diagnoses to give a more accurate picture of what's going on at the very early stages of infection. So to do some of this work, I'm just going to explain where some of this data comes from. So we have a lot of data from both the Philippines and Indonesia. In the Philippines, we've got over 20,000 serum samples collected from suspected dengue cases. Linked to this, we have their PCR status, so we know if they're dengue PCR positive. We know their IgM and IgG status. We know how much IgM and IgG is in their blood. And we also have some basic epidemiological data. So we know their day of illness, which is quite crucial for when it comes to diagnosis. In Indonesia, we have almost exactly the same data, but we have linked to it is RDT results from the NS1 and IgM and IgG tests. So we can almost compare how well these RDTs are working against the ELISA. I'm going to talk a bit more about that later on. But from the Filipino data set, we've been looking at how can we accurately combine diagnostics to firstly determine if a suspected case who's come to a clinic is actually an active case or a non-active case. And a non-active case would be someone who's been misdiagnosed. So they've come in thinking they have, or the clinician thinking they have suspected dengue, but actually they don't have it. They have something similar such as Japanese encephalitis. And we can do this by looking at their PCR and IgM status. So if a patient comes in who is IgM or PCR positive, we're pretty certain these are an active dengue infection because these markers occur rapidly at the beginning of the infection. But what's quite interesting is looking at whether or not we can distinguish between primary and post-primary cases. And just briefly, what we've been doing to distinguish these two types of infections is by looking at the IgG to IgM ratios. So during a primary infection, the IgG is quite delayed and lags, and therefore you have much higher levels of IgM compared to IgG. But in a post-primary infection, because you've already had a dengue infection before, you've already got levels of circulating IgG. So the actual level of IgG is higher than it is for IgM. So this has been, and we've got a paper being submitted at the moment on this, and we're hoping to get this published as soon as possible. But we've just found some quite interesting results looking at this. Firstly, we've been actually looking at some of the infection kinetics and been able to quantify what we suspect is going on with the immunological and viremic kinetics. So we can just, so these two graphs represent both primary and post-primary infections. Along the bottom is the day of infection. So this is these are people who come on the day 1 of their illness, and this is someone who's come on day 5 of their illness. And on the top here in red is the IgG, and blue is the IgM, and in dashed line is the viremia. Firstly, what's reassuring to see is that IgG is pretty much absent during the first stages of primary infection, and the IgM is much higher, whereas in a post-primary infection, that IgG is pre-circulating at the start and at the end, and it's much higher than IgM. So this is quite reassuring results. But what's most striking of all is the differences in viremia. So we can see in this black dash line here, this represents the decreasing level of viremia during the stage of infection. And what we notice is that in a primary infection, that level of viremia seems to be much higher during the first 5 days of disease. Now, we think this could have some quite striking impacts on dengue diagnosis, because the viremia is linked not only to PCR tests, but it's also linked to NS1 tests, because the virus itself is what's secreting the NS1. We also looked into some of the disease outcomes associated with dengue immune status. So this graph on the left here represents our primary infections, on the right is our post-primary infections. And we just stratified basically the symptoms which they're presenting with by age. And in red here shows the percentage of those who are reporting with severe disease. What's first and most reassuring to see is that severe disease is still quite a rare outcome, although it's still present. But what we notice is it's the post-primary infections who are younger who seem to be presenting with more severe disease. And this, that we believe, has major implications for dengue surveillance operations. And I'm just going to show you a quick slide about how we think this actually occurs. So what we've been able to do is collect from all the data we've collected across the Philippines. We've been able to look at the mean provincial age of the primary infections across the country. And what we can see in some of these areas, and for example, the darker blue areas here, this is where people are reporting to clinics at a very young age with their first dengue infection. And we think this is really relevant, is because these individuals might be at risk of having a subsequent post-primary infection, again, at a young age. And we know that having a post-primary infection at a young age can result in more severe disease. So this is an area that we've been exploring quite a lot recently, and we're looking to hopefully get some more cleaner results. But yeah, this is something that there's a lot of further investigation into. But the talk today is more about point-of-care diagnostics. So at the moment, the algorithm relies on these quite laborious, labour-intensive ELISA tests and PCR tests. But these almost sometimes can take up to a couple of days to complete, and certainly, the patient wouldn't benefit from this level of this algorithm at the moment because of these tests. But what we want to know is whether or not existing, or actually new to the market, novel rapid tests can be used to replace the diagnostics already in the algorithm. And what we found, and we used data from Indonesia on this, because for each patient we have their ELISA results, but we also have their RDT results. And what we found roughly is that rapid tests match the laboratory tests. So if we look at this graph on the top left here, we can see this along the bottom is the CT value, which represents the amount of viremia. So the lower the CT value, the higher the amount of virus there is in their blood. And what we can see using binomial logistic regression is that the probability of being an NS1 RDT positive actually increases with increasing viremia, which is really reassuring to see. But for example, what we can say here, if someone has a CT value of 30, we believe they've got an 80% chance of being NS1 RDT positive. And we can do this again for the IgM RDTs against the IgM ELISAs and the IgG RDTs against the IgG ELISAs. And we can basically see that they work really well against these laboratory tests. And then we thought, well, actually, we know we can already quantify the level of antibody and viremia by day of disease. So, for example, we know someone on a primary infection on disease day 2, we know roughly has a mean CT value of about 31. So from that, we can actually estimate what's the probability of them being RDT positive. And then we can do this for both IgM and IgG. And we've kind of collated this into a table here. So again, this table on the top here is looking at the performance of the RDTs for the primary infections, and the one below for post-primary infections. The more red it is, represents how the probability of being positive, and the more blue it is, the more high probability of it being negative. And what we can see on disease day 1, because viremia is so high, you've got a very high probability of being NS1 RDT positive. This decreases during the first 5 days of infection because that viremia is decreasing. But conversely, what we see is actually look at the level of the probability of being IgG positive by RDT is very low, and that's because the IgG is absent during the first 5 days of a primary infection. So there's almost like there's contrasting patterns of being positive to either these RDTs, and using one alone, we believe, can result in missing dengue infections. For example, if you just use an NS1 RDT, there's a chance that you might miss a primary infection on day 5 of their primary infection, and similarly for a day 5 of a post-primary infection. So to combat this, what we believe is actually by combining RDTs, so for example, looking at just whether or not they're NS1 or IgM or IgG positive, you've got a very high probability of capturing a dengue infection during the acute stage of infection. And that's, we believe, is really relevant for case management. So just to finish up, dengue is a really challenging infectious disease to diagnose. And it's not just due to the availability of diagnostics or the contrasting performance of these diagnostics, but it's actually the infection itself. Because you can have different types of infections, and the kinetics change very rapidly during the first few days of disease, it's really difficult to capture that whether or not it's a true dengue infection or not. And then we also believe that actually combining laboratory tests can actually enhance dengue surveillance in the Philippines. But what we want to do is whether or not we can include rapid diagnostics in this algorithm to really inform and help clinicians and healthcare workers diagnose primary or post-primary dengue at the start of infection before they progress to those potentially severe outcomes. Thank you very much, and I shall